present to you Professor Nebojsa Lalic. He is the President's Director and Head of the Diabetes Department at the University Hospital in Belgrade, which is the reference center for diabetes in Serbia, as well as Professor of Internal Medicine and Endocrinology and Dean of the Faculty of Medicine, University of Belgrade. We had the honor to meet Professor Lalic before, and I'm really honored now to present him to give us a lecture on this continuum of complication of diabetes. We heard about the cardiorenal complication, the renal, the liver, and here we are going to talk, or Professor Lalic is going to talk about the cardiovascular outcome results, messages, and dilemma, because really it is a dilemma, and that I hope it will be clarified soon. Thank you. Professor Lalic.
Yeah, thank you very much. Thank you very much again for the invitation and for giving this second opportunity to speak at your reputable meeting. And of course, everything would be nicer if that would be in person, but however, it is good that we are together and sharing the same topics and discussing about that. I'm very much aware of the fact that most of the audience knows about CVOTs and their results. So my intention of today is to speak about some different aspects that have not been so frequently addressed about the results of CVOT, about cardiovascular outcome trials, and some dilemmas that might come from those trials. So in this context, I will compose my presentation in some short introduction, and then focusing on two major drugs that have been focused by the CVOTs as themselves, a GLP-1 receptor agonist and SGLT2 inhibitors, and then to go on with changing their position within the therapeutic guidelines and what that might signify, or what are the changes and what are the points of possible discussion. So let's try with the introduction. We have been, of course, very much surprised and interested, at least, in the results of CVOT trials, focusing patients with cardiovascular comorbidities and or especially overt cardiovascular disease, then renal disease, and knowing the fact that the risk for cardiovascular morbidity in diabetes, especially type 2, is at least 2 times higher than in non-diabetic population. However, at any moment, at any office, we should always bear in mind that it is around 32% of the patients that are frequenting the doctor, the diabetologist, and others, so that we should also take care about the other 2/3 of the population, and especially to search this overlap or the high-risk population, which has been only recently addressed. But of course, the first CVOTs had to be involved with those ones who had overt cardiovascular disease, and that was natural. But about extrapolating those results, it should be done in a sort of real-world settings, in order to finally make the overall conclusions. This is the scheme of the CVOTs. There are definitely more than those ones, and a lot of them have been completed. Some of them are ongoing, and from those trials, as you know, two classes of drugs have demonstrated that there is cardioprotectivity. It is with GLP-1 receptor agonists, and another group. These are SGLT2 inhibitors. And when we say cardioprotectivity in general, we do think as if, and it is something that is usually transmitted to even general practitioners, that those drugs are really preserving from a cardiovascular disease in future. But there are some restrictions in attempts to extrapolate the findings of CVOTs to all the SGLT2 inhibitors or GLP-1 receptor agonists, even based on the findings of the very studies, and of course not speaking about the possible mechanisms that are underlying this very important effect. So, cardioprotective effects of GLP-1 receptor agonists are in fact limited to some of them. It can be ascribed to dulaglutid and liraglutid and semaglutide to a certain extent, but not to those ones that are derived from exenatide and that are functioning more in a rapid way through the slowing of the food flow during the gastrointestinal tract. So it is first of all very complicated to speak about the class effect of those drugs. Then speaking about the study participants, you can see that basically these studies had different proportion of the studies of the patients with regards to the prior cardiovascular disease. For example, the LEADER study had more than 3/4 of those ones who had prior cardiovascular disease, but also 1/4 of those that didn't. And a very convincing cardioprotective effect has been shown, especially regarding cardiovascular mortality. On the other hand, we can compare that with, for example, the REWIND study, in which you will see there is a completely different distribution of the effects, although the cardioprotectivity regarding the main outcomes, the primary outcomes, have been achieved, and not speaking about those studies that like Excel or Elixa that have not shown this cardioprotectivity. How does it look more specifically or more in details? These are results of the main study with liraglutide, in which was the first one with GLP-1 receptor agonist, which has shown a convincing effect, and practically the same extent of the cardioprotectivity as GLP-1 as GLT2 receptor agonist empagliflozin. And on the other hand, there is also rather convincing result in decreasing the cardiovascular death. Although in this study, the effect on heart failure, which was very much present with SGLT2 inhibitors that you will see, was absent in this leader study. It was absent with this SGLT2 inhibitor. Then a sort of study that was not in a strict sense CVOT was done with semaglutide, and very convincing the decrease in primary endpoint, which meant for all of those studies the cardiovascular mortality, then non-fatal MI and non-fatal stroke was decreased for some more than 20%, which was the highest until now, the highest detected until now. However, this study could not, in sub-analysis, could not show the positive effect on cardiovascular mortality as itself. And this was a sort of first of contradictions that we met in these CVOTs. Although one must say those studies were not powered to show this effect, but however, we did not get, we got after obtaining cardioprotectivity regarding the three primary endpoints, we got completely different, the whole variety of different signals with different GLP-1 receptor agonists. That goes then with albiglutide that made the same effect when primary endpoints were concerned, but paradoxically did not have any effect on cardiovascular death, neither on stroke, and had a rather rare positive effect on non-fatal myocardial infarction in the sub-analysis. Albiglutide has been withdrawn until now in a number of countries, so it's not anymore in our focus. If we take just the CVOTs with GLP-1 receptor agonist and try to see the effect on cardiovascular disease, we can say that if the study was done in established with patients with established atherosclerotic cardiovascular disease, we obtained significant positive effect. Some were marginal, but significantly positive effect. However, in these very studies, sub-analysis, in contrast to some single studies that dealt with patients with multiple risk factors, did not show any significant advantage with the GLP-1 receptor agonists when the people with multiple risk factors were involved. So that created a little bit of confusion about what was the message from CVOTs regarding the people at risk. Finally, the last one that came very soon, it was dulaglutide, again with the positive effect on tri-composite endpoint, but in fact the only significant positive effect in sub-analysis was the effect on non-fatal stroke, which is a little bit strange because stroke is not so great part of cardiovascular events in general. There are many things to be explored. What are we going to see from the SOUL trial, which is with oral semaglutide, which is going on with oral semaglutide as the CVOT, and which might show how we are going to end up with the primary endpoint and secondary confirmatory endpoints. It would be very interesting, especially regarding the fact that we will have here GLP-1 receptor agonist that is used orally, which would then be a sort of bridging towards the way how SGLT2 inhibitors are used. What is the mechanism underlying all this? It is very difficult from the CVOT to say much, but it appears to be that GLP-1 receptor agonists do act on preventing atherosclerosis, that their receptors are found on the heart, but not so much on myocardium, and that they are found on the blood vessel wall. And there are some new studies enlarging the area of possible effects of GLP-1 receptor agonists to the liver, preventing the NAFLD and future NASH, and to the adipose tissue. So what would be the basis of the effects that we have noticed previously in the CVOTs is still something that should be deeply explored. Regarding SGLT2 inhibitors, you can see if we go pretty much with the same approach, you can see that, for example, we thought that in many studies, the cardioprotective effect was shown. For example, first of all, with empagliflozin, in EMPA-REG study, then in CANVAS, where only the people with prior cardiovascular disease were investigated, but then also with CANVAS. In CANVAS study, where the population was mixed. Then in DECLARE study, where we have also even preponderance of people without prior cardiovascular disease, and a lot of comments were around that this is a sort of class effect that exerted by this class of drugs. And then, however, came VERTIS cardiovascular study that did not show the cardioprotectivity, all except for heart failure. And this has been done only in those ones who had previous cardiovascular disease. Why is this difference so much present, and what is the basis of almost uniform effect of these class of drugs to heart failure has still to be determined. And you are aware of those results, that empagliflozin had a convincing effect, a signal, because it was the third level. Those were the primary endpoints, hospitalization for heart failure. Then also very hard signal, very strong signal regarding cardiovascular mortality, which was the secondary endpoint, and of course the significant effect on the primary endpoints. And then in CANVAS, again the combination always going on with primary outcomes and hospitalization for heart failure. That has been demonstrated as well in DECLARE in a special way. In primary endpoints comprising the death from cardiovascular disease and hospitalization for heart failure, and on the other hand, the lack of the significance in the conventional, if I can say like that, primary endpoints. That was interesting. This type of analysis has been done with specific statistical considerations because there were two kinds of primary endpoints, and these ones were significant where heart failure was also very much dominant. And but when a sub-analysis of DECLARE was done, patients with prior myocardial infarction got the significance in contrast those ones without primary myocardial infarction. So there is the whole variety of findings in DECLARE that did not match the previous findings in other CVOTs. And if we do the similar analysis with that has been done from the CVOTs, I underline from the CVOTs, then you can see the very convincing effects on those people that had previous atherosclerotic cardiovascular disease and somewhat mild effect on those with multiple risk factors. And the same, however, when this combination of CVD and hospitalization for heart failure has been analyzed in the same way, the effect of SGLT2 inhibitors was much stronger, and we had almost significant. This was a secondary analysis, and that is why it might be, if the samples were done the other way around, it might be significant, but very much different result when the individuals with multiple risk factors are concerned, which meant that the presence of heart failure and the effect of SGLT2 inhibitors might be something which really improves the whole situation by preventing hospitalization for heart failure. Just to mention that SGLT2 inhibitors, even more than GLP-1 receptor agonists, exhibit a very, very convincing effect on reduction of kidney failure, which ranges around 50% in almost any of those studies. And now cardiologists embark in some area which was not envisaged at all from the very beginning, and that was the area of non-diabetes. In DAPA heart failure, it was shown that dapagliflozin was able to reduce cardiovascular death and hospitalization for heart failure, and especially heart failure and hospitalization even in in the population containing mostly non-diabetic subjects. That opens a sort of area in which hypothesis which might be too strong and too extreme is that in fact by looking for a new anti-diabetic drug like SGLT2 inhibitors, we in fact discovered the new drug that is very potent in preventing further development of heart failure. So that we have in fact a drug which has a broad place in cardiology and, by the way, reduces blood glucose. It is not, of course, not everybody would agree with that, but there are a lot of results. There are a lot of results that can elicit this type of discussion. And in this context, what is the mechanism, the main mechanism that is, in fact, that might be backing or underlying the effect of SGLT2 inhibitors? There are the major place is in fact the hemodynamic influence, which goes through reducing of preload and reducing of afterload and reducing of the arterial hypertension and reducing of the changes of left ventricle. All of them are hemodynamic, that prevents the development of heart failure and especially reducing the left ventricle stress. Together with that, there are some changes of mitochondrial energy metabolism, and there is a theory saying that the stimulation of the synthesis of ketone bodies can contribute to the effect of those drugs by providing to the heart those metabolites that are very useful for a failing heart, although not everybody is agreeing with this metabolic hypothesis. So what we know until now is that the effect of SGLT2 inhibitors is basically on the terrain of hemodynamic changes, which then implies the question, what is really their effect in diabetes settings, and how these two effects can be put into the equilibrium. One of the things that has been proven is that there is a marked difference between SGLT2 inhibitors and loop diuretics, saying that SGLT2 inhibitors are not decreasing intravascular volume in contrast to loop diuretics. That came in from the mechanistic studies in this area. Finally, all these the results had an impact on therapeutic guidelines, and this impact came in very quickly, and you're all aware of the fact that treatment of type 2 diabetes comprises to us diabetologists one of the first questions, whether the patient has cardiovascular disease or not, and if the disease is present, then the use of either SGLT2 inhibitors or GLP-1 receptor agonists are advantageous. And of course, there are others, but in other patients also we should take care of the risk of the disease. The same happens with the priority also should be given to patients with the diabetic kidney disease, and due to some recent studies with those ones with very high risk for cardiovascular disease. And the first guidelines of EASD emphasized that maybe the SGLT2s had GLP-1 receptor agonists had a slight advantage over SGLT2 inhibitors when atherosclerotic cardiovascular disease predominates, but there are many papers published meanwhile that contradicts this. And definitely when heart failure or CKD predominates, it is SGLT2 inhibitors that are that are preferable, but in contrast to GLP-1 receptor agonists. Finally, our fellow cardiologists reminded us that nothing, that we should not be that rigid, and try to change, I mean, EASD and ESC try to change these guidelines about how the treatment in diabetes should be introduced. That caused many discussion. But one of the things that I think might be accepted, at least in my view, is, and was not accepted meanwhile, by diabetological community that much, is the fact that if you have a patient that did not use any drugs for type 2 diabetes and goes through an event, cardiovascular event, or chronic diabetic kidney disease, or has a high risk for it, that then we should go with the drugs that have proven cardioprotectivity, which is higher than metformin. That we should abandon, at least for this subset of people, our dogma about the first use of metformin, and then give to those patients what they really need. Of course, this is not exclusive. There might be some combinations. It is individual, but the opportunity that is given by the European Society of Cardiology is something that is very interesting for the discussion, but also for the future practice, to use the drugs that have a better and higher cardioprotective potential. Thank you very much for your attention.
Thank you very much, Professor Lalic, for your nice presentation. Now we have a few minutes for questions, please.
Not an issue. Why we don't combine in all atherosclerotic cardiovascular disease risk the two GLP-1 and sodium glucose transporter inhibitor?
You mean, why don't we combine GLP-1 and SGLT2? Was that the question?
Yeah, this is a question.
I really don't know the answer, because there is a room for that. And especially only maybe regarding the progression of heart failure, in which GLP-1 receptor agonists do not offer any added value. But in other areas, I think that the combination of those drugs might be of benefit, especially in some subsets of patients that have full-blown atherosclerosis together with hypervolemia, together with something with increased preload, afterload, and the changes of left ventricle.
I think there is no contraindication to use them together. If a patient is already in SGLT2 inhibitors with other anti-oral treatment and failed even to achieve the A1C target, all the guidelines say you have to start injectable therapy by GLP-1. So you can add it on top of SGLT2 inhibitors.
Oh, yes. Yeah. Oh, yes. Oh, yes. There might be something which is not scientific and not medical. In many countries, the combination of the two drugs is very expensive. So nobody, maybe the sick funds wouldn't refund that. But anyway, you're completely right. There is no problem of adding the two.
And I remember in the ADA a few years ago, there was a big debate on the use of combination therapy from the onset of diabetes, and this was held by Professor De Franzo, talking about the use of pioglitazone with SGL.
Sorry, I can't hear you.
Was the initial drug, but few years ago, Professor De Franzo in the ADA asked for the combination treatment since the start of treatment, since the start of diabetes, and his advocation to use 3 raw drugs with pioglitazone and SGLT2 and GLP-1 receptor agonists with or without metformin added. And he had a lot of pros. It did not come into guidelines, definitely until now, but it is a probability. I'm not against the idea. If we are talking about cardiovascular outcome trial, this improved and this improved combination can improve more. I think that adding more side effects is a possibility, and adding more price is an important thing on the treatment of the whole population with diabetes when you use it from the start with 2 basically expensive medicines.
I agree with you. I know that Ralph De Franzo just launched that idea. I think even before GLP-1s were there. Yes, SGLT2s were also there. So, but it did not end up in any of the guidelines. That's true. But he said the point of his presentation was that all the possible pathogenetic mechanisms should be covered, and which is a good point. Although we for many reasons, a lot of them being paramedical, did not use this approach for years.
Thank you very much, Professor Lalic, for this interactive session and really very enlightening on a very important topic which we all suffer from. We thank you very much. We hope to see you again in physical meetings in Cairo.
Thank you.
I hope soon it's going to be available. We really appreciate your 2 presentations, Professor Ceriello, and see you soon. Thank you very much. The session is ended.
Thank you. Thanks a lot for inviting me.